generally we think about Parkinson's disease as being a deficiency in dopamine. That's why a lot of the medicines that we give you are replacing dopamine or attempting to replace dopamine or helping dopamine stay around longer or work a little bit better. And this study that was pointed out to me last week really was suggesting the opposite, that perhaps it's actually an overabundance of dopamine inside the nerve cells that's actually toxic to them, that actually causes the disruption or the death of these cells. And maybe we need to be viewing Parkinson's disease in a different light or a different fashion with potential different treatments if you can figure out how to do that. So I went back and read the paper, both the article that referenced this paper and the paper itself, which was actually very difficult to read and very sciencey. A lot of things that even I had trouble wrapping my head around in terms of trying to understand the ratios that he was talking about and how he was coming to the conclusions that he did. And my take-home message from reading that was, maybe he's onto something. Maybe there is a toxicity to dopamine to the nerve cells. But the problem that I have is right now we don't have a way to actually measure intracellular dopamine, at least not in somebody who is still living. All of the data that he got was from autopsy data. And I'm not really eager to autopsy you guys to figure out what to do for you. Doesn't sound like a very good plan. And we also don't really have a medicine that does what he thinks it should do in terms of trying to deplete intracellular dopamine. Now, there is again, you kind of have to think about nerve cells. There's a nerve cell and there's inside of that nerve cell, and then there's everything outside of that nerve cell. And there's some differences between what's where. But at the end of the day, while I think this paper that was brought up had some good insight into it or some reasonable ideas to it, I don't think we're anywhere near actually being able to use it in terms of helping people. I think there's a lot more research that needs to be done in that area. We need to have better ways of measuring dopamine. We need to look into, in some model form, medicines that might do what he was suggesting, which is trying to deplete intracellular dopamine to prevent it from becoming toxic and building up, which I think is reasonable. But I think we're still ways away from that being taken as, hey, this is a novel idea or target in Parkinson's disease, and we should really start treating people as such. Again, I think the idea was very reasonable. And I think it definitely prompts more research. But at the end of the day, I think that's about all I would say about that study from last week that we talked about. The only other, and you'll have to bear with me, so all of my kids were sick. I didn't get the runny nose or the sore throat, but all I got was my voice is terrible, which, as I was mentioning to the other guys, is really a big bummer when you speak and talk for a living. Yeah, it doesn't necessarily go as well. So I am, let's see, I'm 1 Earl Grey, and this is my 3rd green tea deep. So, I'm partying hard over here in neurology. Anyway, I did get one message via email that was basically an interesting idea. So I won't get into all of it because they also wanted to get an appointment with me, which everybody knows is impossible. For some reason, I'm really popular. I haven't figured out why. And for some reason, it's really hard to get an appointment with me. I'm working on that, but not all that successfully. At the end of the day, what I'm told is they have shaking in their right hand. They were diagnosed with Parkinson's disease about a year ago. It hasn't necessarily bothered them to the extent where they had to be put on medicine, which is good. And again, as we always talk about, the medicines themselves are not disease modifying. They are not altering the course of the disease. There is nothing that says you have to take a medicine just because you get diagnosed with Parkinson's disease. I really do wait until the symptoms are problematic before I start putting people on medicines. However, you do have to exercise, which is always my favorite thing to talk about. That wasn't the point of their question. They've been having increasing periods in shaking in their right hand and foot, depression, anxiety, sleeplessness, loss of balance, and joint pain that they haven't experienced before. The interesting part of the question is, how are you able to determine if these symptoms are a result of Parkinson's disease, and what would be the treatment if you wanted to try to attack some of these things? Now, this is a concept that we always talk about. This is a concept that we talk about every time I have this conversation. This is a concept that I talk about in the office all the time. How do you know what's causing what? The short answer is you don't. The long answer is it's most likely Parkinson's disease. As if you've listened to any of these talks or a lot of these talks, I always get the question, is blah, blah, blah part of Parkinson's disease, or is ... a symptom of Parkinson's disease? And almost always the resounding answer is absolutely. Parkinson's disease can literally affect every system in the body, and it does affect every system in the body. And so if you can come up with a symptom, it can be caused by Parkinson's disease. And so generally, yes, and everybody here on this call knows Parkinson's disease is more than just a movement disorder problem. Even though for the first 150 years of what we call Parkinson's disease, we only ever cared about the movement disorders, i.e. the tremors and the stiffness and the walking problems and the balance problems and the slowness of movement. That is actually only a fraction of what Parkinson's disease is. And it's not even the most bothersome fraction. It's just what we have the best treatments for, and it's the most noticeable. And so these were the things that we focused on for the first 150 years. For the past 50 or so, however, all of these other symptoms, predominantly the non-motor symptoms, have become much more front and center and in the limelight. Everything from sleep to mood to pain to going to the bathroom to eating, you name it, it's affected in Parkinson's disease. And it turns out that these are the symptoms that actually cause the most disability or most impact of quality of life. This has been studied. We know this. We're just not as good at treating these problems. And so, yes, the anxiety, the depression, the sleeplessness. What else did I list on there? The loss of balance, the joint pain, which people don't usually think about or associate as Parkinson's disease, are probably all related to Parkinson's disease. Now, the second part of that question is a little bit tricky, which is what would you do about it? And that has about a million different answers. Depending on who you go to, they'll give you a different answer. If it were me, I would probably say, how bad is it? How much are these symptoms bothering you? How much are these symptoms impacting your day-to-day life? Are they keeping you from doing things? The same questions that I ask all of my patients when we're trying to figure out what to do. If the answer is yes, man, this joint pain's really killing me, or man, I can't sleep, or man, my anxiety is through the roof, which has been the common thing over the past 2 years with the pandemic, then I would say, okay, let's do something about it. And at the end of the day, we would pick and choose what we aim for. So again, all of the medicines that I have and all of the treatments that I have, with the exception of exercise, are symptom management. Carbidopa-levodopa is a symptom management medication. Anybody who comes to me with tremors and stiffness and the right kind of slowness of movement gets put on Sinemet. It's not a Parkinson's disease specific drug. It is a symptom specific drug. Likewise, the same anxiety, depression, these are all symptoms. And so really what it comes down to is we pick and choose which symptoms are the ones that are impacting quality of life or day-to-day life or what you're doing the most. And then we figure out what to do about it. If the stiffness or the balance or maybe even the joint problems are the biggest issue, carbidopa-levodopa is probably our best choice. If the anxiety is the biggest issue, we got medicines for that. If the anxiety and depression are the biggest issues, I have medicines for that, but I'd probably refer you to a psychiatrist and a psychologist. This is the team that treats these things the best. And so again, another common theme that I talk about on these calls are, even though all of these symptoms are coming from Parkinson's disease, and I really do think that Parkinson's disease is at the heart of all of these symptoms, doesn't mean that I'm the best person to treat them. If you're having a lot of bladder problems, the urologist is much more knowledgeable about your issues, even if they're coming from Parkinson's disease, than I am. If you're having a lot of constipation or gastrointestinal symptoms or gastric emptying problems or motility problems, I refer you to a gastroenterologist. If anxiety and depression are your biggest problems, a psychiatrist is your best bet. And so even though I think, from what I'm gathering or what I'm reading into this question, that all of those symptoms are likely Parkinson's disease, and no, there's no way to really test that theory, we would still treat it the same, and we would pick and choose what we would want to aim for and then come up with this treatment strategy for that. Sometimes it's medication, sometimes it's physical therapy, sometimes it's speech therapy, sometimes it's occupational therapy, sometimes it's psychotherapy, sometimes it's go get more testing because we need to look into this a little bit further. But the end result, or the end answer to that question, is we really pick and choose what we want to do, and we pick a symptom that is the most bothersome and go from there. Hopefully that answered the question. Doesn't mean you don't have to come see me, even though you can't get in to see me. You should see somebody. All right, now I'll go to the chat box. What is cholinesterase? Well, that's an interesting question. Now, I have to assume you're asking that question because some of the medicines we use are aimed at cholinesterase. Either that or you're just a scientist, and that's a really interesting question to you. So the short answer is cholinesterase is the enzyme that breaks down acetylcholine. So generally we think about acetylcholine in muscle contraction. And so acetylcholine is what makes your muscles contract. Cholinesterase is what then cleaves the acetylcholine so that your muscles can stop contracting so that you're not constantly flexed and rigid. We generally think about cholinesterase, however, in Alzheimer's disease. So the cholinesterase inhibitors, which are Aricept, Exelon, galantamine, I think Namenda works that way. So all of the Alzheimer's disease drugs are aimed at cholinesterase, and I'm guessing that's why you're asking. And so that's what cholinesterase does. How does it work in terms of memory, cognition, walking, and balance? I don't have a great answer for that, but why would I use a cholinesterase type drug in Parkinson's disease? That's probably a more important question, because I do. I put people on medicines like Exelon, Aricept, Namenda all the time. And it's not just when they're having memory problems. and there's really not a great reason, but an important reason. And this is my opinion, although I think I have some data to back it up. It turns out walking in balance in Parkinson's disease is not as much driven by dopamine as it is by acetylcholine. It turns out that the cerebellum, which is the back part of your brain, and the connections between the cerebellum, the brainstem, which is where your spinal cord comes up to meet your brain, and the rest of the deeper structures of your brain, as well as the outer structures of your brain, are more driven by acetylcholine than they are by dopamine. This has been sort of studied, although it's still iffy. We're still trying, believe it or not, even though neurology is not new and people have had brains, we think, for a really long time, we don't know how the brain works all that well, in case you haven't figured that out. We have not figured out all the ins and outs about how brain messages, brain functioning works. There's some data to suggest that acetylcholine works in these back part of your brain's circuits more so than dopamine. And this is not that surprising, right? I mean, a lot of people have walking imbalance problems, and I don't know how many people on this phone call can say, it doesn't really respond to Cinemet or Mirapex. That doesn't seem to impact my walking imbalance all that much. I don't shake as much and I'm not as stiff, but my walking still stinks. It's things like that that tell us that dopamine isn't the all end all be all and the answer for a lot of these things. And I think walking imbalance is one of them. And it turns out acetylcholine might actually be the culprit, or at least part of the culprit, for an area of the brainstem that we think affects walking imbalance in the cerebellum. And so there's a little bit of data, a little bit, not a lot, not good data, to suggest that some of the acetylcholinesterase inhibitors, or medicines like Aricept and Exelon, actually help people with Parkinson's disease have better balance. And that's why, again, if you're my patient, you've probably heard me talk about this or tried one of these medicines if you have balance problems. Or if you're not my patient, this is where you'll see some of my patients who have Parkinson's disease end up on an Alzheimer's disease drug. Does that mean that I think they have Alzheimer's disease? No. It just means that really nothing was invented for walking in balance. And so I have to steal medicines from other categories to see if I can get you walking better. And everybody on this call knows how important walking in balance is, because falls are certainly not your friend. Ending up in the hospital because you fall and break a hip is certainly not a good plan. And so I spend a lot of my time trying to work on, how do I keep you upright? How do I keep you off the ground? Which is how we keep you out of the hospital. And so that was a really long answer to the question of what is cholinesterase, but I think that gets to the idea of what you were looking for and really why, how I'm using it in day-to-day practice. Have safety studies been done on levodopa? Has levodopa caused Parkinson's in any non-Parkinson's patients? Ooh, that's an interesting question. I know the answer to the first question. I don't know the answer to the second question, but I will make one up for you. So the short answer is yes. Tons of safety studies have been done on Parkinson's disease, or I'm sorry, on levodopa. All drugs, when they're approved by the FDA, have follow-up studies associated with them to make sure that we didn't miss something in the drug trials and they are indeed safe. And not only that, levodopa, I think, Cinemet came out in 1969. And so that puts us, 50 years out, 60 years out. And so a lot of studies have been looking at how safe levodopa is. Now, there's a caveat to this. A lot of caveats to this. So let me start by saying Parkinson's disease only affects people. There are no, as far as we know, naturally occurring Parkinson's disease in any other species besides people. Why that's important is we don't just start trialing things in people. It's frowned upon. We don't want to cause toxicity in people before we know what it does. And so we have man-made animal models of Parkinson's disease. And we do this by giving them certain chemicals or certain drugs or doing certain things to them. In some animal models or cell line models of Parkinson's disease, levodopa was thought to be toxic. Levodopa was thought to increase the speed of progression of disease and cause Parkinson's disease. And so this has been brought up for a lot of years. This is not new information. This is old information. This idea has been around for a really long time. But time after time after time, and it's been studied and looked at multiple times in multiple different ways, that has never been shown in people. Levodopa has never been shown, at least to my knowledge, in people to speed up disease progression, cause Parkinson's disease, or be toxic. But because it has been shown to do that in animal models, that idea tends to linger. Now, I don't know why that is. I don't know if it's because the animal models that we do are man-created, meaning we give them a chemical or something to cause them to have Parkinson's symptoms, and that's what leads to this. The reason I don't know the answer to your second question is levodopa is used in things other than Parkinson's disease, predominantly dopamine-responsive dystonia, which is a genetic kind of dystonia that we usually see in kids. It's called Sagawa's disease, or I take care of it in adults. It's just dopamine-responsive dystonia. And even though dystonia is similar to Parkinson's disease, it's actually not the same thing. I don't know that in those patients there has ever been anybody who was thought to then develop Parkinson's disease because of the treatment, not to my knowledge. Again, I don't know that I've ever looked that up. And so if there's case reports out there, I'm not sure. And really, you wouldn't be on levodopa unless you have one of these problems. So I don't think that it's ever been looked at in just, we'll call quote unquote normal people given levodopa to develop Parkinson's disease. I don't think anybody would ever do that study. And so I feel confident in saying, yes, safety studies have been done on levodopa and it is relatively safe in terms of not being toxic and progressing the disease. It has tons of side effects. Don't get me wrong with that one. It comes with its own set of issues, but I don't think it's actually toxic in terms of coming back to the first thing we talked about, which was having too much dopamine intracellularly. I think that's two different ideas. And I don't know the answer to the question in terms of whether it's ever caused Parkinson's disease in non-Parkinson's disease patients, because I doubt that it would ever be used or looked at for that. But if I come across that, I will be sure to let you know. Does Parkinson's disease usually move at the same speed? Part of me wants to say yes, but part of me wants to say no. I know I'm really definitive with these answers. I know you guys love that. My take a stance, black and white answers. They're the best. Well, and I say that because when I'm talking to patients, everybody wants to know, okay, what am I going to be like in 5 years? What am I going to be like in 10 years? I say, well, I don't know. I don't have a crystal ball. I'm not a magician. When I'm explaining it to patients, I do usually say it kind of progresses at a slow, steady rate. So the way that I word it is, the best guess is to look back at the prior 6 months, year, 5 years, and extrapolate that to the next 6 months, year, 5 years. But then I usually follow that up with saying, that's not written in stone. It's not a guarantee. That's just our best guess. So when I'm describing it to patients, I describe it as though it progresses at the same speed, but then I always hedge my bets and throw the caveat in there in that it might not. However, it doesn't usually progress at a certain rate and then all of a sudden take a nosedive. So when I hear that in my patients, so I have a patient who's been relatively stable and all of a sudden they're hallucinating like crazy, or all of a sudden they can't walk, or all of a sudden their symptoms are completely significantly worse, then I'm looking for something else. I'm looking for a urinary tract infection. I'm looking for a pneumonia. I'm looking for an electrolyte abnormality. I'm looking for, did the medication change? Was a new medication added? In those situations, it's almost always something else, because that is not typical progression of typical Parkinson's disease. Now, Parkinson's disease, as we've covered on this talk before, but it never hurts to revisit, is not just one thing. Parkinson's disease is a collection of symptoms. Anybody who comes to me with the right kind of tremor and the right kind of stiffness and the right kind of slowing down and the right kind of balance problems with no other obvious cause gets labeled as Parkinson's disease. However, that is probably not just one thing. There's probably 100 different things that can all end up with those symptoms. And all 100 of those things is going to get labeled as Parkinson's disease. It really is a syndrome more than a disease. And so you can imagine you may have one type of Parkinson's disease, and your neighbor who also has Parkinson's disease has a different type. Those two things may not, but also likely will not progress at the same rate. And so you really can't compare your speed of progression to somebody else's speed of progression, because at the end of the day, you probably don't have exactly the same thing. There's a lot of similarities, and there may do the same thing. They may respond the same way, but they may not. And that's one of the hard things about Parkinson's disease, is it's really not one thing. It's a whole combination of things that all look the same when I see somebody in the office. And so hopefully I answered that question, although I definitely don't know the answer to that question. I'm not going to give you a black and white answer. All right. On an earlier webinar, numbers of confirmed newly diagnosed are increasing as predicted. In my practice or region, are there any noticeable changes in the age group and gender? More or less women, younger, more men, women? Not noticeably, at least not in my clinic or in my office. I would say I still generally take care of kind of similar ratios. My ratio is actually pretty close 1-to-1 men to women, believe it or not, even though I know there's some studies to suggest it's not 1-to-1. But in my clinic, it's actually pretty even. I haven't looked at my numbers recently, but I did a while ago, and they were actually pretty even. And I don't think, so I've been doing this for 8 years now. I don't think I've noticed a tremendous shift in age of onset, age of presentation, men, women, race. I really don't think I've noticed a whole lot of change, in all honesty. I do think the numbers are going up. I think the numbers will continue to go up. I already think the numbers far exceed anything that doctors can handle at this point. Hence, it's so hard to get into our offices. And I think that's only going to become a bigger problem as more and more people end up with the disease. And so I do think the numbers are going to increase around the Pittsburgh area. Again, we actually have a very aged population, second only to a county in Florida, I think, in terms of elderly patients or elderly people. And so we have a tremendous number of Parkinson's disease patients around here. And I do think that that's going to get bigger. It's projected to increase over the next 10, 15, 20 years, much like it has. I have no idea how the pandemic or COVID is going to affect that. We haven't really figured out if that's going to make a boom in Parkinson's disease like it did for the Spanish flu or the encephalitis lethargica outbreak back in the 19 teens and 20s. We're not entirely sure. Is it going to be better, meaning there's going to be less? We haven't quite figured that out. But we do think it's going to keep getting higher and higher. It's going to keep growing in terms of number of patients. Again, I don't think that it necessarily is changing in terms of age or sex or gender or things like that. And so I think that's been relatively the same. And I don't know if that answered your question or not, but at least in my practice, in my experience, I think at the end of the day, it's been relatively the same. However, there is a ton of patients out there that don't come to a neurologist, that don't come to a movement disorder specialist. There's a lot of general neurologists that have Parkinson's disease patients. There's a lot of primary care doctors that take care of Parkinson's disease patients, for better or for worse. And at the end of the day, again, is that why I'm still just seeing the same people or the same type of people? Maybe. I'm sure there's a referral bias to who comes to my office. And so maybe the numbers are changing. I'm just not seeing it in my clinic. It's also a hard thing to kind of pinpoint, as David or the Parkinson's Foundation guys will point out. We kind of have maps of where we think high numbers of patients are, but there's a lot of subjectivity and a lot of error in trying to guess where there's patients are and how many there are. So we're not very good at taking a census, or we're not very good at pinpointing specific numbers. But the long and short is, I do think it's getting more. I do think the numbers are going to continue to increase, and I do think it's going to become a continued big problem in terms of shortages of access to people who specialize in this type of thing. Which actually is a really good time for me to tell you, I don't want to be the bearer of bad news, but healthcare is really in trouble these days. In case you haven't noticed, if you're my patient, you've definitely noticed. Getting back to you and answering messages is not nearly as quick. Not that we were ever that good at it to begin with, but we're certainly not better at it now. And I have a feeling it's not just my office. I think primary care doctors are short. Neurologists in general are short. Nurses, poor nurses. Nurses are the hardest people in the world to find these days. I mean, if you're a nurse, you can get a job anywhere, anytime, for however much you want to make. I mean, there's such a shortage in all kinds of medical people that, man, we're struggling in not just in neurology, not just in Parkinson's disease, but medicine in general is really struggling. Again, not that you need to take that to heart, but just keep that in mind. If you send a message, or to, not just me, to anybody, and you're struggling to get a hold of somebody, struggling to get in, struggling to get a message back, just bear with us. Be patient. We're doing the best we can, but medicine is really in tough shape these days. Anyway, side rant done. Do I know anybody that has had success with acupuncture for tremors or other Parkinson's disease symptoms? I have, actually, which is interesting. So for the longest time, my answer to that would have been no. So I had a lot of patients go get acupuncture, and everybody came back and said, man, maybe it did okay. I don't know, maybe it wasn't all that great. I kind of had lost hope in acupuncture. And then and this was probably 2 or 3 years ago, I feel like it was like 2 or 3 or 4 patients in a row come back and said, man, I had acupuncture and it was great. It really helped my symptoms. I'm walking better. I'm less shaking. And so that kind of restored my faith in acupuncture. So I don't dissuade people from acupuncture. In fact, I don't necessarily say, hey, you got to go get acupuncture, because the data is very limited in terms of benefit. But I'm not against it when people say, hey, I'm going to go get an alternative treatment, or I'm going to go get acupuncture. I just had a patient today ask me about magnetic stimulation, pulse stimulation. And I said, hey, there's not a lot of data behind it, but I'm not against it, as long as it's not putting you in the poorhouse, because unfortunately, these alternative treatments are never covered by insurance. But generally they're fairly safe. And things like acupuncture, I actually have had several patients come back and say it helped. my idea of acupuncture is acupuncture's been around for, I think, like 3,000 years. I was looking it up once, and if it didn't do anything, I don't think it would have survived 3,000 years. I mean, that's a long time for any type of therapy to hang around. And so there's got to be something to it. And again, I really have had a couple of patients, probably even more than a couple now. It's probably been a handful, maybe even a dozen would be a stretch, come back and say, hey, I had acupuncture and it really did help. I find it's temporary. I find that, it helps for a little bit, but much like everything else, it kind of wears off and then you have to go back, kind of like chiropractic manipulation, things of that nature, massage. They tend to be nice early on and then they kind of wear off and they make you go back and do it again and same thing. But the short answer to the question is, yeah, I've had a few patients or a handful of patients have some success with acupuncture for tremors and for other symptoms. So walking, balance, stiffness, pain, things like that. There's definitely something to it. Not a lot of data to support it, but there's definitely something to it. Well, there's green tea number 3. We'll see how that does. All right. Is there any concern that the COVID vaccine can make the symptoms of PD worse? Well, yeah. I mean, there's concern from patients and there's concern from me, because I've had patients come back and say, hey, I had the vaccine and my symptoms got worse. Much like I've had patients get COVID and their symptoms get worse. The short answer is, yeah, it does worry me to some extent that the COVID vaccine can make symptoms worse, but I still recommend everybody get it. My opinion, and this is opinion, I don't think this has been studied or looked at factually yet, is that I've just seen so many bad results of COVID. And again, my vision of COVID is fairly skewed. Sorry, those are hurting my head. And so at the end of the day, being in the hospital, which I do work in the hospital periodically, you just see all the bad things of COVID. And I've seen young, healthy people die of COVID. That's a real thing. That's not a myth. That's not made up. That's not just media. I've seen it on more than one occasion. And I've just seen the devastation of COVID. And yes, I know there are risks to the vaccine. Yes, I know that it can potentially make your symptoms worse. But man, I think that risk is less than the risk of getting COVID. And again, if you think about the way that we make all of our decisions in medicine, it's weighing out risks and benefits, right? The same way that I decide, should you be on a medicine? Do the benefits outweigh the potential risks? Because nothing's free. Everything comes with a price. All magic comes with a price, right? Every medicine has side effects. There's no such thing as a side effect-free medicine. There's no such thing as a side effect-free vaccine. Everything comes with a price. But man, I think the price of COVID is far greater than the price of the vaccine, just in my experience and what I've seen. And so, yes, even though there are concerns about it making symptoms worse, I still recommend it to everybody, because I really do think that it is less risky to get the vaccine than it is to get COVID. Now, thankfully, our numbers are going down. So again, the number across Allegheny Health Network, I think, is less than 20. When it was at its peak in December, or whenever our most recent peak was, we were up over 300, almost at 400 across the health system. And so the numbers are definitely coming way down, but they're not zero. It's still there. Every other day you hear about a new variant in Europe. We're still waiting for who knows what's going to happen there. And so at the end of the day, I don't let my guard come down completely. I still recommend the vaccines, even though I know they have risks. All right. I feel like I beat that question to death. All right. I'm falling asleep after dinner while in my wheelchair. Sometimes it's orthostatic hypotension. Sometimes it's not. What's causing this? If I knew the answer to that question, if I could fix the answer to that question, I'd be a millionaire. I'm not a millionaire, in case you were wondering. So as a whole, fatigue is the number one complaint I get in the office. Fatigue, tiredness, lack of motivation, lack of energy, don't want to get up and do stuff. These are the number one complaints that I get from patients and spouses, usually. And I don't have a good solution for it. It is definitively a Parkinson's disease thing. I have my opinion as to where it's coming from, which I'll tell you in a second. But I have not found a great medicine or treatment strategy to fix it. The only thing that I've ever found helps it, I know everybody's going to be surprised, exercise, my favorite thing to talk about, is the only thing that I've ever had success with in terms of that fatigue and that tiredness. Now I know everybody's sitting there thinking, all right, dummy, I'm tired. How do you want me to get up and exercise? And that's only going to make me more tired. I am well aware of that. You don't have to call me names. I know that. But realistically, exercise is the only thing that tends to give people a boost, tends to give people energy. And it's not because I like talking about exercise, although I like talking about exercise. It's because I've literally tried everything else that I can think of in some patient or some form, and I have not had a lot of success. So could it be orthostatic hypotension? So this is where blood pressure drops, right? So a lot of patients with Parkinson's disease have autonomic symptoms. So your autonomic nervous system is your nervous system that controls automatic behaviors, heart rate, blood pressure, going to the bathroom, sexual function, sleep, you name it. Things that happen automatically. And blood pressure is the one that comes up the most. So a lot of my patients, when they stand up, they get dizzy. So in quote unquote normal people, when you stand up and all the blood rushes from your head to your legs, you have mechanisms in place to prevent that from happening. Your blood pressure goes up, your heart rate goes up, you pump more blood to your brain, you don't get lightheaded, you don't get dizzy, you don't pass out. That mechanism does not always work in Parkinson's disease. So I have a lot of patients who, when they stand up, those mechanisms don't kick in, or they don't kick in quick enough, blood rushes to their legs, they get dizzy, lightheaded, and sometimes pass out. So that can definitely make you tired. If your blood pressure is going down, that can be part of it, but that is not all of it, because a lot of my patients that don't have orthostatic hypotension still come in and complain of fatigue and tiredness. Afternoon time is also a particularly bad time. So 2, 3, 4, this is from what I've been taught. I don't think I ever looked this fact up myself. This is what I was taught. That is the time when everybody, you and me both, naturally make the least amount of dopamine. And so that is a time when a lot of my patients take a nap, are tired, feel exhausted. Dinner time can be close to that. So that could be part of the issue as well. But coming back to the fatigue and it being the most common complaint that I get, I really do think that this is a side effect of the disease itself. And at least my own internal explanation, meaning the way that I describe it and explain it in my own head to allow myself to wrap my head around it, is that if you think about what you guys do on a day-to-day basis, and if there's significant others sitting there, think about this in terms of what you don't have to do on a day-to-day basis. So if I want to get up and walk down the hall and get a drink, I just do that, right? I don't think about my steps. I don't think about my arm swing. I don't think about pushing myself up off the chair. I don't think about my balance. I don't think about, navigating things. I just do it. It happens naturally, right? I learned how to walk when I was probably like 5. I feel like I was delayed, but that's a whole different story. Anyway, again, we all learned how to walk, and once you learned how to walk, you stop thinking about it. That is not true in Parkinson's disease, right? Every single thing that you do requires thought. You can do anything. You can stop your hand from shaking. You can talk in a loud voice. You can write big. You can swing your arms when you walk. You can take big steps. You can stand up straight without your wife yelling at you to stand up straight. You just have to think about it. And I really do think that it's all that thought process that goes into what should be automatic behaviors that really is the fatiguing process. I really do think it's tiring, mentally tiring, when you have to think about every little thing that you want to do. And I think this is the case because everybody said, it's not a physical tired. This isn't like I just went to the boxing class and now my muscles are tired, or I just ran a marathon and I'm physically tired. It's a mental exhaustion. At least I think. Again, this is my own opinion. None of this is fact. This is all my own opinion from talking to patients and trying to wrap my head around an understanding. It really is a mental fatigue and tiredness that is what people are experiencing. The problem with that is it doesn't respond to medicines that well. I've tried more dopamine medicines. I've tried stimulants. I've tried caffeine. I've tried antidepressants, thinking maybe this was a depression problem, working on serotonin. I've worked on epinephrine and norepinephrine, which are, your alertness chemicals. I have tried medicines for just about every chemical I can think of, every aspect of, brain anatomy that I can think of. And I've had very little success. And that leads me to believe that this isn't a physical thing. This is a mental thing. This is a mental exhaustion. And that's what makes it really hard to fix with medicines. I don't know how. I honestly don't know how, but exercise really does work for that. I've had a lot of patients come back and say, I'm more alert, I'm more awake, I'm not napping as much when I go to the gym or when I go for a walk or when I do a boxing class. Now, this may not be true for everybody, but I've heard it enough times that it's worth repeating to you guys to let you come to your own conclusions. It's a really hard problem to fix, but it's the number one complaint that I get coming to my office. So I don't know why or what's causing the fatigue in you per se. It could be your blood pressure, no doubt about it. It could be this fatigue that I hear about so often. I don't have a great solution for it. It's not something that I'm really all that good at fixing. And really, my go-to answer is going to be, instead of going and taking a nap, get up and go for a walk, or get up and do a little bit of exercise and see how you feel. I hear 10 times a day, every time he sits in his chair, he falls asleep, right? How many people out there are going to nod when I say stuff like that? Everybody. And of course, my first answer is, well, don't sit down in the chair, get rid of the recliner. But the second answer is, get up and move more. You will be much less likely to fall asleep if you're up, if you're moving, if you're out of the house. Again, these are all things that you can try changing in terms of your day-to-day life to see if we can work on that fatigue, see if we can prevent that napping. Again, it's not for everybody. Everybody has something a little bit different, but these are just common themes that I get every day in my office and everyday complaints that I get in my office. And this is how I go about trying to figure out what to do about them. So again, I don't know if I answered your question specifically, but that's how I usually approach the idea or the topic of fatigue. And believe me, it is an important topic. It is a common topic. Every day I answer this question, or where we try to figure out what to do about it, multiple times a day. See what you can come up with. How long does it usually take for extended release Cinemet to start working, and for how long? That's a good question. I don't have a good answer for you, but it's a good question. The obvious answer is everybody's a little bit different. In my experience, the controlled release Cinemet doesn't work as well. So usually the immediate release Cinemet, in my experience or my patients, generally takes about anywhere from 10 to 15 minutes to kick in, which is probably really quick for a lot of people. Most people say maybe a half hour, 45 minutes. Some people say an hour. That's kind of the range that I hear for the immediate release carbidopa levodopa. The controlled release is a little bit worse than that. So a lot of people don't really feel it kick in, which is why I don't like to use it during the day. And so if I had to guess, I would say on average, maybe 45 minutes, an hour or something like that. But everybody's a little bit different. Again, there are a lot of different varieties of carbidopa levodopa. You name it, it comes in that type. So there's immediate release, there's controlled release, there's a combination of them both, there's an inhaler, there's an intestinal infusion, there's everything except for a patch, which we've been waiting for a really long time. And they all generally have different rates of kicking in or wearing off. And they're all variable for everybody. And so you just kind of have to try it and see what happens. Now, again, because I don't get a lot of patients that have had a lot of, hey, I really feel that it kicks in, it works pretty well. I don't use a lot of controlled release during the day. The one time I'll use the controlled release levodopa is at night, when you don't really need to feel it work as well. It just needs to last longer. And so again, if you're having trouble with the kick in of your extended release. Maybe you need to switch to a different version. Again, this would be a good question or a good topic of conversation for your Parkinson's disease specialist, your neurologist, your movement disorder specialist, because there are a lot of varieties out there. And again, this also brings up an important theme that I know I talk about a lot, but is so important, I feel like it's worth mentioning, is that you really have to have good conversations with your neurologist, with your movement disorder specialist. You got to bring things like this up when you're in the office, or send a message. Yes, I know it's hard to get in touch with us. Yes, I know it's hard to get responses from us, but you got to try. And then you got to be patient because it does take us forever to get back to you. But at the end of the day, these are the conversations that we want to know, because this is how we decide, hey, maybe the Cinemat CR is not the right choice. Maybe we need Rytari. Maybe we need the immediate release, but we also need to add in the inhaled levodopa, the Ambrosia. Maybe we need to switch completely to something different like Mirapex or a Nupro patch. Maybe we need to supplement with the Cinemat. I have plenty of patients that take a little bit of both, Cinemat CR and IR. And so you name it, it's possible. But these are the kind of conversations that you really should have with your doctor to try to figure out, okay, what is the best way to accomplish whatever you're trying to accomplish? And how do we adjust to make that happen? Again, I know I talk about it a lot, but lines of communication really are important, especially when you're in the office. Again, not to give you the kind of behind the scenes picture of medicine, but so generally on average, I'll see between 15 and 23 patients a day. I generally get 20 patients for a return, 20 minutes for a return patient and 40 minutes for a new patient. I have a feeling that's probably pretty standard no matter who you go see. And so that 20 minutes that you get with me is really dedicated to what are your biggest problems and what do we need to work on to try to get you doing better. Yes, you can send us messages after hours or when you're not in the office. And yes, we'll try to adjust accordingly. But that short amount of time that you get in the office with us is really the best time to try to talk about stuff like that. Yes, I know there's 1,000 things that we have to talk about in that office visit, but that's really the area we're bringing up, especially medication things. Hey, my medicine's not working as well as I would like, or, it's wearing off early, or it's not really kicking in. These are all things that talking about face-to-face is really good, because then we can ask follow-up questions like, hey, is this every time you take it, or is this just in the morning or the afternoon or the evening? What else have we tried? What do we need to do to try to get you doing better? And so all of this can be discussed in an office visit so that we can really tailor the treatment strategy to what you're doing. So again, not telling you what to do or kind of giving you some insight into how we work as doctors, but again, things like that, while a good question, really is something to bring up within your next office visit, because maybe there's something we can do to get you doing better. That's a really good question. I like this question. Is there one aspect or symptom that patients avoid mentioning in appointments that we wish were mentioned sooner? Yes and no. I mean, nothing specific, except for, should I still be driving? Nobody wants to bring up that question because nobody wants the answer to that question. But outside of that, I mean, really, at least my patients, and maybe, I try to keep it open so that they feel comfortable bringing up whatever they want to, or at least I try to. I would hope you wouldn't have any reservation in mentioning symptoms to me. And if you don't, generally, the other good part about my patient population is a lot of people, or the vast majority of people, come with somebody else, a significant other, a kid, a neighbor, a friend. And so if the patient isn't always forthcoming with what's going on, whoever they bring with them almost always is. And so I can't think of any one aspect. Sexual dysfunction is probably something that we don't talk about as much because people don't like to bring it up, but they should. Driving is something that people should bring up more because we should probably talk about it more. Anxiety and depression is always a touchy subject because nobody wants to hear you should go see a psychiatrist for some reason. Everybody thinks as soon as I tell them they should go see a psychiatrist that I think they're crazy, which is ridiculous. Psychiatrists are just the best people to deal with anxiety and depression, and that's how they should be viewed. But man, getting somebody to a psychiatrist requires an act of Congress. So maybe that's one thing people don't like to bring up is depression. which you should, because there are things we can do about it. And so I don't know that there's any specific symptoms that people feel a little bit shy or weird about bringing up, but you really shouldn't. Again, another really big take-home message is, doctors, I mean, I play a mind reader on TV, I think, but realistically, I'm not very good at reading your mind. You really do have to tell me what's going on for me to know what's going on. And it's so hard to try to read between the lines. You're much better off, or you will get much better treatment, or much more direct treatment, if you say, look, this is what I've been dealing with. This has been my problems. I don't like bringing it up, but this has been an issue for me. You don't have to be embarrassed about any of your symptoms. Believe me, we're doctors. This is what we're here for. And you should not be shy or feel bad about bringing something up, because guess what? You probably are not the only one who's dealing with all of these things. And yes, I do know something that we can do about everything. I don't always have the right answer or all the answers, but I can come up with something. And so your best choice is to have an open line of communication with your doctor. You really should bring up everything that's bothering you. You should not feel bad or shy or ashamed or scared or anything that you're going to get judged, or that, we're not going to be able to help you, or that we're going to laugh at you or anything like that, because that's just not the case. We really are here to help you. And realistically, the more you bring up, the more forthcoming you are with information, the less I have to work to get to the information, the easier it's going to be to get you on the right path to treatment. And so some of the things I mentioned are things people don't like to bring up, but at the end of the day, you guys really should bring up everything that's really bothering you. Anything that's really impacting your day-to-day life, as minor or major as you think it is, you should have that open line of communication with your doctor. The issue that we're dealing with most troubling is nervousness and anxiety. That's actually not an uncommon thing. Does the Cinemet help at all with this? I mean, part of me wants to say yes, but the greater half of my brain thinks that the true answer is probably not, or not a lot. At the end of the day, well, so an intro, I didn't see, I should have read the whole question before I started answering. Interestingly enough, they say he especially feels it when his Cinemet is wearing off. So if that is the case, and this is again where one of the things that I've talked about a lot, or a lot of my take-home messages, is patterns, right? Paying attention to patterns of your medications, patterns of your day-to-day activities. How are the things that you're noticing in relationship to when you take your medicines? If it really is a wearing off, and people feel terrible when they wear off, they feel anxious, they feel depressed, they have pain, they're stiff, they can't move. The wearing off can feel really bad, from what I understand. If anxiety really is a wearing off, then yes, Cinemet might actually help with that. But for run-of-the-mill generalized anxiety, which comes, according to statistics, anxiety and depression is 50% of Parkinson's disease. I think that is a far underestimate of anxiety and depression. I would say it's over 90% of Parkinson's disease have some form of anxiety, depression, mild, major. Some aspect of it is going to be almost everybody. In general, if I'm dealing with anxiety and depression, it's not something that responds to levodopa very well. We really do have to tackle that individually, either with medicines, getting it to a psychologist. I really like psychologists, because a lot of these things, I really don't want them to just medicate you. I would much rather try to work through the problems with coping mechanisms, things like that. And so I actually prefer psychology to psychiatry, but that's my own opinion. But a lot of times when I'm dealing with these problems, they're not something that levodopa fixes. However, in this case, if it really is a wearing off of the medicines, then more levodopa or more dopamine medicine might actually help. So again, take home message, open line of communication with your doctor, paying attention to patterns, particularly in relationship to your medicines. These are all really important things when we're trying to figure out what to do, right? Again, at the end of the day, when you come to me, or you send me a message, or you send me a phone call, I have to figure out what to do about it, right? It's my job to come up with what are we going to do to try to help you feel and do better. And all of this information really plays a role in what I come up with. What type of medicine we try. Do I just give you more of what you're on, or do we need to try something different? Is medicine even the right choice? Can we get you to therapy, physical therapy, speech therapy? Can I get you to a psychologist? You know, all of these things are options. And the more information you can give, the better I'm going to be, or your doctor is going to be, at trying to figure out what is the next best choice. There's always choices. There's not always good choices, but there's always choices. And that's what we have to try to figure out. And with that, I think I have answered the last question that's currently on there. And I don't know how much more my voice is really going to work for me anyway. And so at the end of the day, I think I'm going to stop there. Again, as long as you guys keep throwing questions at me, I will keep doing this. I find it enjoyable to come give you spew as much information to you guys as I can. And hopefully you guys get something from this as well. David, anything else from your guys' standpoint? Any take-home messages? Or Christine or Casey? I think I saw you guys on there. I'm going to take that as a no.
Hold on.
Oh, go ahead, Kate. Sorry.
Hi, we're all here. We're just struggling to unmute and put our videos back on. Thank you so much, Dr. Leichliter. You're always amazing, even when you're sick. We just want to encourage everyone to look at all the wonderful programming we have upcoming. Of course, we have our conference on Sunday, and we hope some of you will be there. We have a Washington Wild Things game coming up. In May, we have an opportunity to do a paint monkey where you get to paint a tulip, and we are going to enter those tulips into a program for the World Parkinson Congress, and you have an opportunity to win 2 tickets, all expense paid trip to Barcelona for the World Parkinson Congress. So we have lots of fun things coming up. So please do read your emails from Casey. The newsletters are amazing and filled with all sorts of information. So come be with us.
Absolutely. Thanks, everybody. Have a good month, and I will see you back next month.
Thank you.
Thank you. Hope you're feeling better too.
I'll be fine. Don't worry.
Thank you.
Bye,
Y'all
everybody.
look beautiful.